please make yourself comfortable. We have a very interesting webinar with a lot of great information. So get ready. This is a 75-minute session. I'm so sorry. I think you can hear my background with a lot of noise. Is that true? Information. So I would love to welcome everyone to this webinar on catastrophic costing. A very important point. Really, we will hear from excellent speakers today. I would welcome everyone to use the Q&A to put your questions. That will make it easier for a panelist to respond directly to your specific questions. We will have a wonderful moderator with us who will also pull in your questions into the panel discussion after everyone has spoken. You can use the chat to say hello and introduce yourself. It's always nice to know who's joining us. Please do so. But if you can use the Q&A for any questions, that will make it easier for us to moderate. The session is being recorded, so you will be able to access it afterwards. We will also share all PowerPoint presentations. We are live streaming right now on YouTube, and I'll put the link to the YouTube in the chat, which is also the place where you can find the recording. You can turn on subtitles for your own use. And we will be sharing afterwards a news report with all the details and for your easy reference. We're live streaming also on various social media posts, so you can click and retweet some of the information. So this is it from my side. I am very pleased to welcome Dr. Saba Wasim. She is going to be taking us through today's webinar. She is the technical director for health financing and management sciences for health, and she leads MSH global work in health finance and system strengthening for TB. So she's the right person to take us through this webinar today, and I'm handing over to Saba. Saba, please, it's up to you to introduce this webinar and our wonderful speakers of today. Thank you so much. Looking forward.
Thank you, Petra, and thank you so much for organizing this webinar, which is on a very important topic, especially in these days. So we're going to be talking about, and my name is Saba, as Petra introduced, and I'm not an expert on this topic, so I'm looking forward to hearing from all our experts that are gathered today. So we're going to be talking about the high out-of-pocket expenditures that TB patients or people that are families that are confronting TB face. And the reason for why that is such an important topic, we as TB practitioners, we are very well aware that it's a very key reason for TB patients for not accessing services or for dropping out of treatment. And that has a key impact on the outcomes, health outcomes for the TB patients themselves and for the community. So as TB practitioners, we know very well that this goes beyond altruism. It has a very real public health impact. So this conversation is very timely and very important. So we know from there is a certain amount of literature, and this has been a topic that has been discussed for a long time, that TB patients face high out-of-pocket cost, especially even though TB services are free in a lot of or most of the low and middle income countries that we all work in. But a Lancet study that Petra has actually put together a list of studies that we can provide for you later shows that, they continue to face very high costs. So on average, they can face up to, $500 for even just direct costs of medical services, and non-medical services, $200 for medical services and indirect costs. And these are concepts that I will ask our esteemed guests to talk about. But they face, we know that it's the poorest households that face catastrophic costs. Again, the definition of catastrophic costs will be provided to us later today. And when we looked at MSH, we had conducted a TB Financial Sustainability Index analysis, and we had conversations with an assessment that we conducted in 12 different countries with TB high priority countries. And we found that this is one area of work that, even though government has policies in place, that have not been very effective. And high out-of-pocket expenditures continue to plague households, despite policies being in place. Several countries have policies that are providing direct support. And they have health insurance, which is addressing the direct medical costs. They have supplemental support like direct nutritional support, which is addressing the direct non-medical costs. Very few have TB patients linked to social protection schemes. So that would address the non-medical costs, for instance, the transport costs and things. So what we have today, we have a group of experts that have looked into this. They are all economists and epidemiologists and done a lot of research into the TB costs. So they have looked into what are the key drivers and what is the current status of TB costs in different countries. And once we have that discussion, then I would the presentations, and I would encourage you all to talk about to ask questions about what is it that especially from the perspective of private sector, because we all are working in the private sector space, what is it that the private sector can do to mitigate and to address these issues? So today we have we have Ines, who's from the World Health Organization, and she's a senior health economist, and she's been leading the work on developing the TB household cost survey methods. So we'll start off with Ines. Then we have Boni. Boni comes from Indonesia. She's also a medical doctor and a senior epidemiologist, and she's worked with MOH, NGOs. She's been working in this space for a while. She's going to present to us some data from Indonesia specifically, and she's also going to look at what patients in private sector as well as public sector face, the costs that they face. And then we have Carmen. Carmen Christian she's a development economist and a PhD in economics, and she's at the University of Western Cape. She's going to talk about her findings from South Africa and the implications for policy from her findings. And then finally, we have our friend Professor Venkat, who's going to talk about about India, and will also focus a bit on his specialty, which is private sector engagement. So he will talk about what we can do as private sector experts to ensure that the private sector has a key role in mitigating these. So without further ado, I would like to invite Ines to start us off with her presentation on the global findings. Ines, over to you.
Thank you, Saba. Is the sound okay? And my sharing of screen okay?
Yes. If you can go on presentation mode, that would be great.
Yes, in a minute.
Thank you.
Let's see if I find... Hang on a second. I'm sorry, I can't find the... There. Yes. So I'll be presenting on a stream of work that the WHO has been leading since 2015 on surveys of cost faced by households affected by tuberculosis. And I'll provide the definitions, the methods that are followed, and give you an update on the progress with monitoring these costs since 2015 to 2024. So the WHO's NTB strategy includes one of three high-level targets: that there should be no TB-affected families facing catastrophic costs due to TB. And the target was already... Yes?
Could you go to display settings in the top? And yes, and then go to slideshow. Perfect. Now we can see the full screen. Thank you.
So as I was mentioning, the World Health Organization has one of its 3 high-level targets that there should be no families facing catastrophic costs due to tuberculosis. And the UN high-level meeting for tuberculosis that was held in September 2023 also includes a target that all patients affected by TB should be covered by social protection and do not face catastrophic cost. So in this context, there was a stream of work that would that WHO was promoting to monitor the economic burden of households with TB. And the reason for doing this is that TB-affected households suffer from heavy financial burden, as Saba was mentioning, and it presents a barrier to early diagnosis. It causes treatment interruption and loss to follow-up, and it further impoverishes TB-affected households. And this is not just a consequence for the families of patients, but it's also for the whole society, given that it further increases disease transmission and drug resistance. I'll put this here. Sorry, 1 second. So I'll just move this here. And so TB household cost surveys are an instrument that provide information to improve the delivery of TB services, but also to enhance relevant social protection schemes. And in order to respond to this need of monitoring the NTB target, WHO convened the development of a methodology that started in 2014 with a systematic review of patient cost studies done till that date. Then we convened a task force to develop the generic protocol and an instrument for patient cost surveys. We then field tested, and in 2017, we launched the publication that you see on the screen in pink and blue cover, which is actually the manual for survey conduct. And this year in 2025, we're actually launching the second edition of the guidance, which includes several updates that I will mention later. So the objective of these surveys are threefold. First is to document the magnitude and the main drivers of the different types of cost: direct medical, direct non-medical, and indirect, that are incurred by people treated for and their household. And also to determine the baseline percentage of the TB-affected households that are incurring catastrophic total cost due to TB. And then a third objective, which is actually, it was not included in the first methodology in 2017, but we are keen to include it in the 2025 methods that will be soon published, is that we are encouraging to also include the determining of the baseline percentage of use of existing policies to mitigate cost and socioeconomic impacts on TB-affected households, and recommend refinements of existing policies and design new ones based on survey results. So again, we are, this is to assess the economic burden for tuberculosis from the patient perspective. And the methods or the survey design include a facility-based survey on a national sample of people on TB treatment. It's a cross-sectional nature, so the interview of the patients happens once. And the cost of these studies average 100,000, and it takes around a year or even longer than a year, or a year and a half, to conduct from protocol development up until the dissemination of results with the stakeholders and multi-sectoral action plans. So with the data collection being 2 to 3 months in high-burden settings. In terms of sample size, we're looking at around 600 to 1,300. Some high-burden countries have gone beyond this sample size, but we are looking around this number, and we have a minimum of 20 clusters of basic management units of tuberculosis to collect data from. And the questionnaire, which lasts around 70 minutes, includes 130 questions, and we tend to collect data preferably on an electronic format rather than paper. And all the material, so WHO has disseminated generic protocols, generic instruments, as well as the manual, so that countries can adapt and yet keep a standardized method to allow also global comparisons and monitoring of the results. So what are catastrophic costs? So these are defined as direct medical cost plus direct non-medical cost plus indirect cost, which can be either income loss or time loss valued by salary, which you can do in sensitivity analysis. And this compared to an annual household income. And if costs are higher than 20% of the annual household income, the household is classified as incurring in catastrophic cost. Now, the survey doesn't just monitor the proportion of households that are incurring catastrophic cost. It's actually providing a wealth of indicators that allow to measure elements such as coping mechanisms. So families may take loans or sell assets in order to face the economic burden that TB imposes on them. It also measures social consequences, so divorce or separation, food insecurity, interrupted schooling, job loss, social exclusion. It also assesses access to social protection schemes, including job protection, salary compensation, sickness benefit, food and transportation support. And in addition to this, and this is very important, it monitors changes in the household income, and it measures it against poverty levels and measures the level of poverty before the TB symptoms, at the time of TB diagnosis, and during treatment. So a wealth of indicators that can help get a picture on what are how the economic burden is impacting families with TB. So up to date, 37 countries have implemented the survey, with 13 surveys ongoing right now and 7 planned. And there's repeat surveys ongoing in Vietnam, in Brazil, in Myanmar, and also in Tanzania, that are currently being implemented, and where results will be able to compared to their first baseline survey. WHO, through the Global TB Report series, publishes every year the estimates of the proportion of households facing catastrophic cost based on the survey results. So the graph that you have on the screen shows that the proportion varies from 13% in countries like El Salvador to 92% in Solomon Islands, and the global pooled average is that 1 in 2 households that are on treatment in public facilities or in private, linked to the public notification system, incurring catastrophic cost. And the percentage is much higher for people with drug-resistant TB. It goes up to 82%. So what do countries do with the information that is derived from these surveys? They establish policy measures to mitigate the costs that are identified in the survey. An example on how Ghana used the survey results to mitigate direct medical cost identified in the survey, which accounted for 19% of the total cost. It's that the NTP and the National Health Insurance Authority identified low health insurance coverage among TB patients. And so given that 20% of people with TB were uninsured, in 2018, the Ghana Health Service and National Health Insurance Authority agreed on the need of people with TB to be enrolled in the National Health Insurance once diagnosed as TB, without payment of an insurance premium. Another example from Laos on how they designed a policy to tackle direct non-medical cost is what you see on the screen. So the nutritional supplement and additional food cost accounted for 35% of the total cost incurred by TB-affected households in Laos. So 60% of MDR TB patients were with malnutrition. And the National Nutrition Strategy to 2025 had a strategic objective to prevent TB-related malnutrition. However, no actions were planned at the time of the survey dissemination. So what was introduced after was that the NTP and the National Nutrition Program were conducting an intervention study assessing malnutrition in TB diagnosis and impact on nutritional counseling and support on catastrophic cost and TB treatment outcomes, where and it was completed in 2024. And so the enrollment showed that 41% were with a BMI under 18.5. Another example of a national survey that and the measures that were designed was in Vietnam, which Vietnam was one of the first countries to implement the TB household cost survey. And in the indirect cost, so the income loss as part of the cost borne by the households in Vietnam accounted for 44% of the total cost of the households. And so the Ministry of Home Affairs established a new nonprofit fund in 2018 called PAS-TB, that stands for Patient Support Foundation to End Tuberculosis, to encourage people to support TB-affected households. So people would use a mobile phone to type a message that said TB to the number 1402, and they donated in dongs. And in 2023, PAS-TB supported more than $500,000, around $500,000 and with $500,000 equivalent, and approximately 9,000 people with TB. In terms, so on this work stream, just to mention that some of the WHO work that has been recently released is in 2023. Six more countries completed the data collection. And in February 2023, we published a summary of 20 surveys conducted between 2025 and 21 using the WHO recommended methods. And we included a comprehensive documentation of the survey methods, results, and policy translation, as well as country profiles for each of the country surveys, standardized, including the policy translation section, where how it was explained how countries were using the evidence from the surveys to move the policy measures that I have given some examples of. And in October 2023, there was also a modeling study done and published in the Lancet that was modeling the proportion of catastrophic cost in all low and middle income countries, so it included the 20 surveys where data had been collected through primary research, and for the other countries where survey data had not been collected, it was modeling it, and the study is available for everyone through the Lancet Global Health. And we also renewed the roster of consultants that are trained to support countries implementing these surveys. And in terms of this year's 2025, we are actually about to publish the updated guidance on methods to conduct the surveys. And the main updates of this guidance that will be disseminated in the coming days, actually, is that we have revised the terminology from speaking about TB patients to speaking about households affected by TB. And we also speak about people on TB treatment, which is the focus of the study. We also added this third objective on social protection policies that I mentioned earlier, and the methods for sampling and analysis were refined, where we stress the need to aim for equal sampling by treatment phase, the use both of output and human capital approaches for estimating indirect cost. So with output approach used mostly in the main analysis, and human capital approach for the sensitivity analysis. And we also recommended the inclusion of cost of other household members on the TB treatment or TB preventive therapy and caregiver time, which is a novelty compared to the 2017 methodology. And we also provide examples of dissemination of survey results and the formulation of policy options. And we continue providing support to countries on first and repeat surveys. Now, the challenges we now have is that funding for our department has stopped at the end of 2022. So it's affecting particularly the support at global level, so at my end and my colleagues' end, and in the WHO African region, where a lot of surveys are being conducted as we speak. And we were able to support 24 countries with these activities until the end of 22. And this resulted in standardized high quality evidence to inform policy. And there's actually a strong demand for technical support in conducting both first and repeat surveys. So, for especially from high burden countries. So out of the 49 high TB or TB HIV and MDR TB countries, 17 have not yet started planning for the first survey. Here I'm sharing with you some recent publications. I understand the slides will be shared with all of you so you can access. And just to mention that our team is available for support and information sharing as needed. And I thank you very much for listening.
Thank you, Ines. That was very informative for going through the methodology and the concepts, and I'm sure this is a very excellent resource. And also talking about the policy implications and what action countries are taking. Thank you, Ines. I will turn over to Bonnie. Bonnie, and I'm sure there are questions for you, Ines. Bonnie, can you make your presentation now?
Yes, sure, Saba.
And please, let's stick to the time so that people have a chance to ask questions. Thank you.
Yes. Okay. Can you see my screen?
Perfect.
Yes, perfect.
Okay, yes. Okay, so first of all, I would like to thank the organizer, Petra, and also the colleague here for inviting me as part of the panelists for this session. So actually, this is one of the work that I did in 2017, I guess. And then we had an opportunity to again measure the out-of-pocket cost of TB patients in my city again during COVID in 2021. So this is like two cross-sectional study we do. And yeah, and I will tell you later what is the story. So yeah, this is the outline. So yeah, okay, so Indonesia is currently ranked second country with high burden of TB. And most of these patients have barriers to diagnosis and also treatment. And then we also find some of these patients, when they're in the clinic, they also experience a lot of out-of-pocket costs for having their diagnosis. And after the diagnosis made, they also have some delays in initiating treatment. Sometimes they don't have money to buy the drugs, etc. So this is like the real problem we face at the clinic in our daily basis. Like we face TB patients with economic problem. They cannot afford the diagnosis or the treatment. So that's why we try to measure what actually the out-of-pocket costs that experienced by this patient. So we conduct a cross-sectional study in my city, in Bandung. So Bandung is the capital city of West Java, where West Java contributed like 20% of the highest TB cases in Indonesia. So we first measured the cost as part of the INSTEP study we called in 2017, where we interviewed newly diagnosed TB patients at the time of diagnosis and at the end of their treatment. So at that time, we only include drug-sensitive TB patients to be interviewed. So we basically refer to these handbooks, and then we have like a list of questions in terms of a questionnaire, and then we validate it in our setting, and we managed to interview almost like 500 patients at that time. So we basically ask about the direct costs, hospitalization costs. I think Ines has explained this theory very well. So we just adopt like what we have in the guidebook. Yeah, and then what we learned from this study is that first, there's significant difference of when the patient's diagnosed with history of hospitalization or not. So we, of course, would expect that those diagnosed with hospitalization would have higher costs compared to those without hospitalization. And then also the pre-treatment diagnosis cost is also higher among those recruited through the private providers. We also see that 67% of our patients reported that they had been hospitalized as a consequence of their TB. So either for TB diagnosis or they have something complication during the treatment, so they need to be hospitalized, like higher liver functions tests, etc. And then we also learned that travel cost is also like a barrier for the patients, because sometimes to get the treatment, they have to be referred to hospitals. Yeah, so from this, we can conclude there are at least 4 factors that leads to higher pre-treatment diagnostic costs. So first is not having health insurance. So for those without insurance, they spend more, like $41 compared to those having national or private insurance provided by the country. We call it BPJS in Indonesia. And then those, of course, with having more visit to healthcare providers, of course, they spend more. And then patients who present more than 60 days between the first symptoms and diagnosis, they also spend more. Of course, this is like understandable because maybe they delay and their symptoms become worse. So there are more diagnostic tools needed for diagnosing TB. And then the last factors is being presented to private providers or informal providers. making patients to pay more as well, compared if they can go directly to the community health center. So here in the private provider, they can pay like $40, in informal provider around $32, but while in the community health center, they only pay around $13. So it's very big difference. So if they can go directly to community health center, they would pay less. Yeah, and then if we measure the post-diagnosis cost, so the overall or the median cost per person, we don't count for hospitalization, is around $25. So even though the treatment, the TB drugs, the TB medication in Indonesia is free of charge, there's still some indirect cost that patients need to provide during the TB treatment for 6 months. And then again, the patients spend more if they're being treated at the private providers. And then also hospitalization, if during the post-diagnosis, they need to be hospitalized due to complications or others. And then again, travels, we observe still the main drivers of other indirect costs that related to the out-of-pocket cost for patient. So we also measure that in terms of indirect costs, like 86% who were the breadwinner, the income earning job before their illness reported income loss. Yeah. And then the median personal income loss was quite high, like $152. So this is really significant. And surprisingly, those recruited in public hospital tends to have more highest personal income loss because of TB. And then if we measure the total cost, so the direct and indirect cost, so the median total cost per person is $243. So this is substantial, I would say, in terms of TB treatment. And of course, this is maybe because we also include hospitalization, and then we observe that this cost is substantial if the patients were hospitalized in the private hospital. So in terms of coping mechanism, so we observed that 1/3 of these patients borrow money to cover their TB-related cost. And some of them, they might sold their assets, mostly jewelry, to cover it. And then from our study, we calculated around 27% of these patients face catastrophic costs. And Ines already mentioned that it's the cutoff is 20% of the household income. And then in 2020, yeah, the Indonesian have like a patient cost survey nationwide at that time. And then the result is even higher, like 38% than what we have in our study. So I have a chance, and the team have a chance to do the same thing actually, but we did it in 2021. So it's during COVID. So the paper is accepted and in public, and it will be published soon in PLOS ONE. So we see the same. I mimic the same methodology with what I did in 2017. So for before COVID, we have the TB diagnostic method at that time is smear microscopy. But during COVID, since 2021, we changed TB diagnosis to WHO rapid molecular diagnostic using the gene expert. So this is like this smear microscopy era, and this is the gene expert era. But then in terms of the median pre-treatment direct costs without hospitalization, it's just almost the same. So it means that patients still come for multiple visits, even though we already have expert at that time. And then again, those with hospitalization still pay more, and it's like comparable between before COVID and during COVID. Hospitalization is again the highest cost item, following by diagnostic and also medications, and it's quite similar. Travel, also the highest cost item for indirect cost. And then we see that additional costs originated because at that time during COVID, we have a screening cost, like rapid test, sometimes PCR, that constituent to the higher cost for out-of-pocket costs at that time during COVID. So if we compare these two, so the first two boxes is actually, so this one is the before COVID, and this is during COVID. So these two actually, they still share the same problem. So multiple visits still the problems in our setting, because patients go to many places before they finally get diagnosed with TB. That leads to higher cost. And then we also see that still visiting private providers at the beginning means that patient needs to pay more. So there's something we need to do here. And then also patients with symptoms more than 60 days, not having insurance, and then being diagnosed in private sectors, making patients need to pay more. Yeah, this is something that we also observed during COVID, like there's a decline in people with TB proportions with adequate incomes, and then 91% of our study participants reported having financial difficulty, they being laid off because of COVID, and only 61% they reported that they're less willing to seek care, even they have symptoms. And then there's also changes in the healthcare facility, like shortening the operational hours, and then there's also COVID-related measures, and then also limited access because of the restriction. For the coping mechanism, it's almost the same. So mostly they borrow money or they sell what they have. They sold their property. So from these two studies, I still see that patients experience a complex diagnostic pathway and health-seeking journey. And this is also highlighted with two things, that they visit more than 6 healthcare providers before finally diagnosed, and then they first seeking care from private providers or informal providers. And this led to a substantial cost before diagnosis. And hospitalization become the largest cost component. And for the indirect costs, the travel expenses are more significant. And then these people with tuberculosis also experience income loss during TB treatment. And we also see that these pre-treatment costs remain high during COVID. And then I think this pandemic also make it worse for TB patients, become extra burden for them. Yeah. So here I also would propose something that we can do. So first is how we can strengthen the TB referrals and diagnostic pathway. This is really like easier to say than done. Like I see, like I did like different 4 years observation, but we are not like not there yet. So we need still to working on this, and like strengthening referral process, streamlining diagnostic service, raise awareness, and then enhance private sector involvement. So I think the private sector in Indonesia have limited access to TB diagnostics, so compared to the public sector. So there should be like some agreement or some, I think business model would be nice if this can improve the involvement of the private sector and promote health insurance enrollments, because in the previous study we see that not having insurance leads the patients to have higher cost for out-of-pocket cost, and develop innovative social protection policy for TB patients.
Thank you, Bonnie. If I may interrupt. So we're running 15 minutes behind. Thank you very much.
Okay.
And we have some questions also for you. Yeah, thank you. That was excellent.
Thank you.
I'll hand over to Carmen. And Carmen, I'm sorry, but if you can gallop through your presentation, then we can have questions. Yeah.
Yes, thank you so much, Saba. I will try my utmost to do that. I just kindly recommend that everyone switch off their cameras so that I maintain bandwidth while I speak. Thank you. Okay, great. Hi, everyone. So over the next few minutes, hopefully less than 10, I'll be sharing highlights from South Africa's very first national cost survey for patients with TB, as well as some implications and a few thoughts to consider. So I like to start my very statistical type of presentations with this slide to always remind myself that there are humans behind each and every single statistic presented. So South Africa conducted the very first national TB patient cost survey in 2020, 2021. So this was not my study, this was the National Department of Health study, and they worked very closely with the World Health Organization, of course, because they used the 2017 protocol that Inez described so beautifully. But the full report is not out as yet. In the interim, I'm just sharing some high-level findings, which were shared by our National Department of Health last year. So I'll dive straight into the distribution of patient costs. So very similar to what Inez and Bonnie have already shared with us, we can clearly see that indirect costs, those income and time losses incurred by the patient, that is by far the greatest share of patient costs in the South African context, coming in at 70%. And this is followed by direct non-medical costs, which take up about a quarter of that distribution, and that's for things like travel, food, nutritional supplements, and so on. And as expected in the South African context, where the majority of TB is treated in the public sector, it's a notifiable disease, and if it lands up in the private sector, it must be referred to the public sector. The direct medical costs came in at less than 10%. So let's dig deeper and look at time losses. So overall, we found that health visits were generally high, and as expected, drug-resistant TB patients required 3 times more visits. Drug-resistant TB patients also lost more time due to hospitalization compared to drug-susceptible TB patients. And finally, caregivers also lost time due to taking care of patients with TB. So having worked on an 8-hour day in the methodology, drug-susceptible TB patients in the South African context lost about 8 days. Drug-resistant TB patients, a whopping 40 days lost, and 2 days for caregivers. And what this translates into are indirect costs, implicit costs that are impacting severely on the economic well-being of our patients and their households. Over to total episode costs. Again, as expected, with drug-resistant TB patients, they incur higher costs compared to drug-susceptible TB patients, with their mean total of costs being double that of patients with drug-susceptible TB. So as shown in my very first slide, when I looked at the distribution of costs, when it comes to the main driver of TB patient costs, they are the income losses. And if we break that down between drug-susceptible TB patients and drug-resistant TB patients, it's 68% and 80% respectively. When we look at the main driver of direct non-medical costs, we find that it's nutritional supplements, so vitamins and immune boosters that are being recommended to patients. And I mean, all of us sitting here are probably on some type of vitamin or immune booster, and we can surely attest to how expensive those are. Now we turn to catastrophic costs, and again, using the 20% threshold over here. So what percentage of households affected by TB spend at least 20% of their income to stay on their TB journey? So overall, we are looking at 56% in the South African context. That's at least 1 out of every 2 households with TB that are being catapulted into dire economic suffering because of catastrophic costs. And when we break this down and compare drug-susceptible TB patients to drug-resistant TB patients, we can see the percentage is higher as expected in the households with drug-resistant TB patients. Let's turn to international comparisons of catastrophic costs. So South Africa's cost estimates fall in the mid-range amongst the surveyed countries. If you look at the green box on the right-hand side, for drug-resistant TB, South Africa's estimates are comparable to the DRC, Burkina Faso, and Uganda. And with drug-susceptible TB, our estimates can be compared to Zambia, the DRC, and Burkina Faso. And this is mainly attesting to South Africa's extreme degree of income inequality, since TB is concentrated amongst the poorest. So even though we are an upper middle income country on average, as classified by the World Bank, when it comes to diseases of the poor like TB, the struggles of our poor are similar to those experienced in lower income countries. When we look at the pooled averages of catastrophic costs, it's about 50% for drug-susceptible TB and 80% for drug-resistant TB. And when we compare South Africa's estimates for drug-susceptible TB, they are close to the pooled averages and below the pooled averages for drug-resistant TB. So you may be wondering and asking yourself, how on earth do these households cope if they are experiencing such high levels of catastrophic costs? Well, they use a mixture of strategies, none of which are ideal for the poor, but it's often the only source of relief. You can see they are taking out loans, probably at high interest rates because they're high-risk clients, which perpetuates economic hardships into the future. Savings, the little that they do have, is also being spent. And then we don't expect poor to own assets, but for those who do, they are selling it. What about the social consequences? What are they? Again, there's a mixture of consequences. Leading the pack is social exclusion. So stigma still remains a big problem when it comes to TB, as well as food insecurity. And this is followed by job losses. And just yesterday, I presented at a TB symposium, and a patient shared about being ostracized at work for having TB and eventually losing his job. And in terms of food security, I can tell you all the nursing staff I speak to who work in the clinics, some of them are actually paying out of pocket to buy food for their patients while they're on the TB journey. So you may ask yourself, so what type of social support exists in South Africa? Well, in our context, over 90% of our patients don't have any health insurance. So they are accessing care via the public health system. And in terms of TB and other primary healthcare diseases, care is free at the point of contact. And that would be direct medical costs, right? But what about social assistance? Yes, we do have social assistance. We've got temporary disability grants that our TB patients qualify for. We have an unemployment fund. But if you looked at the results of the survey, you will see that only 1/3 of patients are accessing these social assistance forms. And often this is because it's such a laborious process to go through. And when you are as sick as you are, when you have TB, you don't complete that journey. What about food parcels? We highlight food insecurity as a big social consequence. Only 6% of patients receive food parcels. Now, during the COVID-19, when a lot of donor funding was halted, that led to the closure of many food programs that patients with TB piggybacked on. And I'm sure those that remained, the few that remained, are probably going to be closed very soon, or if not now already, because of recent halts in donor funding. So where does this leave all of us? Here are some high-level implications and some thoughts to consider. So in the South African context, there is clearly a need to address high catastrophic costs. as well as its enduring impoverishing effects. We now have a baseline. This was our first survey, but we've measured it. We know the magnitude of the problem, so we can work from there. Inevitably, along with short and medium-term interventions, it is going to require longer-term and broader approaches that includes addressing the social determinants of health. And this, of course, requires a multi-sectoral approach. It's really impossible for the National Department of Health to tackle TB by itself in the South African context. We need all hands on deck, including the private sector. Many of you in the audience here are from the private sector, so I'm preaching to the converted, you already here. But what we know about the COVID-19 pandemic, what it made super clear to us in the South African context, is that all these stakeholders, those that I've listed there, they can come together and make a plan. For example, we have the rollout of vaccines at private dispensaries. But the main difference and the uncomfortable truth is that COVID affected all, irrespective of socioeconomic status. But TB is a disease of the so-called poor. So under these conditions, it's often very useful to use incentives to drive behavior change, to encourage TB-specific activities and programs and intervention that involves other bodies, other institutions, other stakeholders where they have different objectives and TB is not top of mind. But at the same time, we have to be mindful that any time we use incentives to drive behavior change, there will always be unintended consequences. And so this requires frequent monitoring and evaluation, and also considering that context change rapidly. Final slide with a few more specific thoughts on the South African context in terms of what can be done. A very low-hanging fruit would be to increase the ease of access to social protection. We have a really good social security system infrastructure in South Africa that was built during apartheid, but it was built to serve a minority. After the democracy, it expanded and had to accommodate the majority of our country, and now the system is feeling that pressure, so we need improvements there. In terms of reducing food insecurity and the cost of nutritional supplements, we can become very creative and innovative with our partners and incentivize use incentives to do that. And then finally, when it comes to decentralized models of care, there is still a lot of space in the South African context to utilize that. So what I'm suggesting is that in terms of maybe to reduce facility visits, hours spent seeking healthcare and accessing, we can do it. We did it during the pandemic. We used extremely innovative ideas with the private sector, like the home delivery of medication using Ubers. It worked so well. We can use similar models for TB as well. And then my last point, and you know, this one sees at the grassroots level when you interview the frontline staff, is that the public health system needs to create an environment where staff feel they have the freedom and the autonomy to experiment and create different types of interventions and needs. Thank you so much. I am done.
Thank you, Carmen. And I'll keep my camera off. This has been really very illuminating. And I think we'll have some questions at the end. We will now turn to Professor Venkat, and then we can have questions after that. Petra, is Professor Venkat able to join?
I can see Professor Venkat is here. Prof, can we hear you?
Can you hear me now?
Yes, we can hear you now. Perfect.
Yes.
Great. So I am joining through my mobile for the audio.
Perfect.
But the video will be here. So
can you join your screen, or do you want me to share screen for you?
Please do, Petra, help me.
Okay, I will do that. Carmen, can you stop sharing?
Yeah, in the
Thank you.
meanwhile, thank you so much, Sabah. Thank you, TBPPM Network, and thank you, Petra, for giving me this opportunity. I shall be trying to speed it up as quickly as possible. I know that we are running out of time. So
Yes.
let me set the context. I think much of it has been said about the kind of a catastrophic expenditure, the manner in which it is, assessed, etc. So let me try to get to the next slide, please.
I'm getting there.
Yeah, just to set the context, all of you are familiar already that India is the highest burden TB country in the world. Uh, we also have a very robust, very dominating private sector, so to say. Three-fourths of our outpatients and three-fifths of our inpatients, so that is hospitalization, is sought in the private health care in a general context. But specifically with the TB care, close to 60 to 75% of the first contact for TB patients happen to be in the private sector. And more than half of the cases continue to seek treatment from the private sector. Now, in terms of the household income, this is a context I'm trying to set so that you are able to understand the catastrophic kind of expenditure that happens. It is assumed that poorest 40% of population has less than 2,300 US dollars. This is household income. Whereas per capita income, as per the Global Inequality Report, 50% of India's people have a average per capita of just about $800. So these are two distinct ones. One is household, other one is at the individual level. Next one, please. Yeah, in terms of the cost of care in India, it's important to understand that there is no single, indicator because India is very diverse. There are 28 different kind of provinces and with a very different kind of per capita income. So therefore, the cost estimates need to be understood from the point of view of both direct and indirect costs, as some of the studies have shown. A survey of 2021 had indicated that it's about $453 for the total cost of treatment. In another study with a larger proportion of surveyed representatives, this came out to be close to $711 for the entire treatment. A recent study by Jayashree et al. In 2024 indicated a very diverse set of expenditure in terms of 386 as the median health expenditure, total expenditure towards seeking healthcare services, specifically TB care, with a minimum of $132 to a maximum of 877. The median for the people without health insurance was $464, and the median, or rather a range, for those who have been hospitalized was between $900 to $1,100. And for those with the DRTB cases, $496, and 700 for the uh, private sector notified patients. And those who have sought treatment in the public sector, it was $367. Please remember, these are all estimates based on the survey. So we don't have specific information about the average cost across the country. So indirect cost, as everybody here had mentioned about indirect costs, it came to about 66% of the total cost, very close to what South Africa was Catherine was trying to mention. The review of 2022 average total cost was equivalent to 39% of the total annual household income, very similar to what is there in the other countries, specifically in the South region. Can I go to the next one, please? In terms of catastrophic expenditure, I go to the second point straight away. The recent review noticed that 7 to 32% of TB affected households in India faced catastrophic costs. Another cohort study estimated between 30 to 61% of participants, please remember not the households, participants faced catastrophic costs if indirect costs were added to the entire total cost. For half of the households, between 44 to 59% of costs, the reason for the catastrophic expenditure became even before the treatment began. That means that during diagnostic stage itself, in India, 8 to 11 pre-visits had happened prior to the proper diagnosis. So let me move to the next slide, please. Yes, in terms of mitigating strategies, in India, we have tried using a different kind of strategies to cushion down the kind of expenditure that individual patients have suffered or households have suffered. Free diagnostic and treatment was always there with the public sector. As of now, under the new partnership guidance, we have expanded this scope of services to be given in the private sector also for those patients who are seeking care in the private sector. There is a financial assistance for nutrition program. It's called the Nikshay Poshan Yojana. It used to be $1,000 per, it's 1,000 rupees. That's about USD 12. Direct to benefit transfer, we call it as cash transfer directly going to the individual TB case account. This is per month. This has been now changed to 3,000 rupees. That's about $35 per quarter to each patient for the first 2 quarters in advance, and 1,000 rupees, that is 12 rupees, $12 per month for the next remaining period of their treatment. The Ministry of Railways have given concessional rail travel for the TB patients. So they would have to fill up their status while seeking the railway reservation. There is also transportation incentive for people living in the tribal area and also remote areas. This is for the purposes of traveling towards diagnostics. It's a one-time cash transfer to the people. Next one, please. There is a new strategy that has come up, which is called a Nikshay Mitra, wherein we are trying to mobilize the CSR, private sector, corporate social responsibility funds for nutritional, vocational, and livelihood support. So far, 300,000 Nikshay Mitras have been registered. More than 3 million food packets were delivered to the TB patients till the time when this data was collected. There is another group of health scheme which is called the Employee State Health Insurance Scheme, which is for those employees who work in small scale industries, small and medium enterprises, where their per capita income is $250 per month. For these people, if they fall ill under TB, they get a paid holiday or a medical leave for about up to 300 days. And also they get a reservation of hospital beds for in TB hospitals, especially for those working in mines and among the BD workers. There is a Ministry of Labor new policy on how to handle the TB cases at workplace. There is also incentives given to TB care support staff, especially those with DRTB and drug sensitive TB cases. Can I go to the next one, please? You are all familiar to the private sector engagement strategies that we launched in 2019 in India. Under this, we also are giving incentive private individual practitioners for case notification as well as for treatment completion, which is about $6 per case notification and $6 for successful completion of treatment. There are several other strategies that we followed in the last 5 years. And during the COVID period, there had been a slight delay in the full implementation of the partnership guidance for the private sector engagement. During the question and answer, I can answer some of these questions. Can I go to the last one, please? Yes. In terms of options, I was only loud thinking about this, but we would be hopefully including some of these options in our national strategic plan for 2025 till 2030. One of them is the demand side financing, especially during the diagnostic stage, where a patient could be given a kind of a voucher for seeking a right diagnostic center for getting their diagnosis done more scientifically. Second, another proposal that we are trying to include is to have more of an integrated package of services covered under our Ayushman Bharat scheme, which is the Prime Minister's National Social Health Insurance Scheme. This may have a gatekeeping role wherein those who are empaneled under the Social Health Insurance Protection Scheme could also have a screening for TB and suspected TB cases. Remaining ones are the ones we are now trying to experiment in terms of our new partnership guidance, mobilizing and contracting the private sector. We are also proposing for strategic purchasing of services, especially for extrapulmonary cases as well as drug-resistant TB cases. Please remember, since the cost of indirect costs are the highest, who will actually subsidize and cover their catastrophic expenses? Will it be the Ministry of Health or should it be any other ministries? Is something that needs to be really debated and discussed in terms of whether governments can do cash transfers to them till their treatment is completed. I stop here. Thank you so much.
Thank you, Professor Venkat, and thank you also for that focus on the private sector and the options that are available. That is very helpful for us to further questions. And I think there is a few questions that were posed in the Q&A and that have been answered adequately. If folks have any other questions, they can put them in the Q&A. But meanwhile, I think there are a couple of questions for you, Professor Venkat, from Ines directly. And one of the questions that Ines has asked, Ines, do you want to voice over your questions maybe? That'll help everybody.
Sure.
We can turn our cameras back on.
Okay. I was just wondering if Professor Venkat could elaborate on the provision of the references for the strategies to mitigate cost, such as the labor law that he was mentioning. And then he also mentioned that beyond direct cash transfers to mitigate indirect cost, there could be other options explored. And I was just wondering which ones he had in mind, and knowing that the Social Protection Ministry can also have a big role in this, given that TB response is not just the business of the Ministry of Health. It's a multi-sectoral response that we have recognized is needed and that is promoted since 2015, actually. Thank you.
Thank you, Ines. The social security measure that I was mentioning is that there is an Employee State Insurance Act in India where they have provisioned for people who suffer from TB may have an opportunity to avail paid leave up to 300 days. So this act is by the Ministry of Labor. That's one. In terms of
it's well implemented. Is it followed? Is there a monitoring of its implementation, or is it more the framework and theory and this? Actually, surveys could monitor such a
and also in addition to that, the question also whether it covers the informal sector, because there are huge numbers of people that are affected that are in the informal sector.
Great. I don't think the informal sector gets covered. Any companies that have been registered with a minimum of about 20 employees, they come under micro and small scale industries, and they are expected to provide a minimum wages along with a certain kind of deductions, which gets into a kind of a pool of resources for the Employee State Insurance Act. And the Employee State Insurance is a trust-based kind of, I mean, when I use the word trust, it's a kind of a pooling of premiums made by labor community. And they run a large number of hospitals, a network of hospitals across the country, wherein the patients who are registered under the ESI Act can seek any kind of healthcare services, including TB care services. So this is Labor Ministry's oversight role. It is an act, not just a guideline. So it's legally binding on this.
Thank you. Yes. Okay, if there are further questions, but meanwhile, I will ask Ines. Ines, so from what I understand, the surveys that you have been talking about, that the WHO has been running, they cover public facilities mostly, right? And
it's
private facilities.
Public facilities and also private that report cases and notify cases nationally.
Okay.
So
do you think
so basically private engaged with the NTP network, not the non-engaged.
Non-engaged ones, yeah. And do you feel that that's an area that needs further work, that the ones that are not engaged, because we know that that is a gap, right? Private facilities do not report or engage with the national public system.
Yes. So the sampling of basically the sampling frame for these surveys are the patients notified in the year prior to the survey. So unless we have that record, we cannot sample in a random cluster manner.
Yeah. Yes, thank you. And for Bonnie, if you can talk a little bit about the impact of JKN and health insurance on reducing out-of-pocket, because there is some very positive news that direct medical costs in JKN has had a very good impact, right?
Yes, Sabah. So in Indonesia, the JKN is very helpful. Unfortunately, it doesn't yet cover 100% of the Indonesian population. So that's the challenge. And the good thing is the JKN is well structured under the public hospitals. So then there needs to be more engagement to the private sectors, Sabah. Yeah.
Thank you. And there were a few questions for you, Bonnie, that were in the chat, and I see that you have responded to that. There is another one for you, which says that you show that the CHC had the least pre-treatment associated cost. Do they provide comprehensive services, diagnostic and treatment? Would the level of services affect the costs?
Am I allowed to just answer the question here, Sabah? Would that be okay?
Yes, please go ahead quickly. Yes.
Yeah. Okay, so thank you, Saravin, for the questions. Yes, so the community health center is like we call it the primary care level. They provide services, and the good thing, they also have the decentralized rapid molecular test for TB, and that's all covered by the government. So I think that's explain why the cost there is considerably cheaper than at the secondary or tertiary level care. Yeah.
Thank you.
Yeah.
And Carmen, one question for you. You talked about the high level of indirect costs and the need to link with social protection and other agencies that are, the labor agencies. So what are the barriers in South Africa for that? And is it because it's a state level or province level decision and that there's less collaboration, that multi-stakeholder engagement that's necessary that Ines was talking about?
Unmute myself. Thank you, Saba. So when it comes to social protection in South Africa, our patients have access to a temporary disability grant. Unfortunately, there are barriers to access, and in the Q&A, I've actually attached a paper by Van Leer et al. From 2022, which goes into more detail about it. But first of all, at the clinic level, the patient needs to make contact with the doctor, who's often the person who completes these forms and has to sign it off, and then determine whether the patient is qualifying for it or not, to assess the degree of temporary disability. Once that hurdle is overcome, the patient then needs to go and get a lot of other documents, like the identity documents, bank statements, etc. And that needs to be submitted as well, standing in a queue at the social security agencies. These are still long lines because we have such a high burden of people who rely on social security in South Africa. And patients are sick at this point in time. And throughout that process, they just become tired and give up. They literally just give up. They want to get better. So those are some of the practical barriers to accessing the social security grants in our context.
Thank you. And I think what Professor Venkat mentioned, that prepayment of benefits is very important. So thank you, everyone. We are unfortunately run out of time, but this was a very enlightening discussion. And it's great to see all this information that's coming out from different countries. And I hope that we will be able to meet together again and to discuss the policy implications further and what the private sector can do to address these issues. So I'd like to again thank all our panelists for their time and for the effort they put into this, and to our participants for their excellent questions. Thank you, everyone.
And thank you to Saba for wonderful moderating of our webinar. Thank you all to the audience for your excellent questions. It's great, and thanks for answering the questions in the Q&A. Well done, everyone. I learned a lot today. Excellent presentations, really appreciate it. We will be putting all the presentations, including the recording, on our website. We will share it widely. There will be a report. There's also news reports available. So the audience and anyone who has registered for this webinar will receive this. Thank you to the over 100 participants that have registered for the webinar. Really appreciate your interest. Super important topic, and let's keep going. It's World TB Day next week. We saw John Green's book is launched. Thank you, Carmen, for putting that up yesterday. So there is a lot of interest in TB around the world. Thanks everyone who's working on tuberculosis, and wishing everyone a very good World TB Day to make the right noise so that we can keep this fight going. Thanks everyone. Our next webinar, before I forget, will be next week on Monday, together with Partners in Health, where John Green will be speaking as well. So please join us at that webinar, and we wish everyone a really good week, a good weekend, and a happy World TB Day. Thanks, everyone.
Thank you so much.
Petra. Thank you.
Thank you,
Bye.
Petra.
Thanks, everybody.
Thank you all.
Bye.
Thank you.
Bye-bye.
Bye.